finish a session. I'd like to thank you everyone, and I would like to welcome Dr. Feren, Dr. Samuel Matthew sir, Dr. Paul George, Dr. Das, and Dr. Ejilan, Dr. CVN Murthy, Dr. Joy Thomas, Dr. SM Ashraf sir. We'll the technique mastery sessions. How I do it. Over to you, so Feren sir.
So, dear colleagues, good afternoon, and thank you for the invitation. I hope you can see now my slides. It's correct? Can you see?
Yes, sir. Yes.
Thank you. So I think this is one of the most important topics in the cath lab, how to manage bifurcation lesions, including distal left main stenosis. And we know it was a really big problem and troubles in cath lab for many years, because we believed initially there is a plaque in the carina region, and if we open one side branch or one branch, we close another one, and it was really a problem for many years. Now we learned how to protect the side branch, how to do kissing, how to perform different double stenting techniques, and now we are really able to manage in very good way this bifurcation lesions, including distal left main. So we will find in around 20% of cases lesions in with bifurcations, and distal left main will be around 5%. When should we protect the side branch? This is important message to younger doctors. If you have a side branch diameter with more than 2.0 millimeters, or if you believe it could be an option to go with bypass grafting, then you should just put some floppy wire as a standard wire just for protection. You should know there are in some cases very difficult side branch approaches with practically retrograde wiring options. So you can use Swan-Mack technical approach, or you can use it even some micro catheters with angulated tip. We use this in at least once a week in our cath lab, and other options will be dual lumen micro catheter. So another very important question: should we always perform predilatation of the side branch? And the question is very clear. We don't need systematic side branch predilatation. So in more than 90% of cases, to start with side branch predilatation is not really necessary. So, but there in daily routine, there are a few cases with a really subtotal stenosis of the side branch, and in combination with calcification. And if the side branch lesion is longer than 10-15 millimeters, then we have to consider to perform predilatation. And of course, if we perform predilatation in such complex scenarios, we probably need to start with double stenting approach. And the wire protection is important because in many cases, according to the literature, you could really have bad flow in the side branch of the main branch stenting. So it's going something between 1 and 50%. So to have the side branch wire is always a beneficial point. And of course, you predilate the main branch, whatever you use, and C balloon, sometimes the bulking techniques, and then you usually stand the main branch, perform pot, kissing, final pot, and then you are ready usually. It's really very important to implement this approach. Proximal optimization technique pot is extremely important because we have to choose our stand according to the distal diameter, and in this case we would have here proximal mismatch and malposition. So to manage this, you go with the short balloons according to the proximal diameter, and then you can easily cross to the side branch. Sometimes it's even not really necessary. And according to the study situation which we have, Nordic first study, Nordic 1 study was first study, compared systematic double stenting with single stenting. There was no significant difference. In our study from Bad Kreuznach, the BK1 study, we saw really the similar result, very similar result. Even if you perform everything perfect, you don't have benefit after 9 months if you perform re-angio and QSA analysis. And even from British study BBC1, we had even some information that if you go with a complex approach as an initial approach, you, in this case, crash culotte, you have even more problems according to the higher rate of periprocedural infections, so compared to the provisional T-stenting. And you know this data, even if you follow up the patients for longer time, you have impression after 2-3 years, there is a curve separation telling us there is a maybe higher mortality in patients with double stenting. But don't forget, this is all studies were done with first generation drug eluting stents. And we have now different technical approaches. We have TAP, which is very popular in Europe. We have culotte, and now a double culotte stenting, dicky culotte stenting, and double kiss and crush. And you can see here in this approach, in this slide, which approaches are now, at least in Europe, usually used. Provisional, of course, the simple one. If you need additional stent, you can go with TAP or culotte, and both approaches are, as well as bailout approach as a primary planned double stenting approaches. You can use it in both ways. And if you go with dicky crush, then it's practically by definition you start with always with the stenting of the side branch and crush the side branch stent. And you should always take into account how is the anatomy. And if you have a large branch, a large bifurcation angle, you could try to go with a TAP. This will be most suitable technical approach. Culottes and dicky crush by very large bifurcation angle are not really suitable. If you have very small angle here and large side branch, culotte will be perfect. Also here, go with dicky crush. TAP stenting, because of this very long metal neocarina, will be difficult. And sometimes you have really mismatch between side branch and main branch diameter and small angle. This will be a perfect case for dicky crush. And our friend from ABC main club, from ABC club, the European Bifurcation Club, Yanis Chachidis, he has done some very nice animations, which I would also like to show you. So you stand in TAP, the main branch, you make the pod procedure and the short balloon, then you rewire very close to the carina, open the struts. You can do this in a single balloon maneuver or kissing. Then you put the side branch stent with minimal protrusion and perform kissing and perform final pod. It looks now really very nicely. And next step, we will have view into the stand from inside. So there is a minimal protrusion. And if we just take a look to the carina, it's nicely modified carina, and there are no struts floating into the main branch room. And if you just take a look to culotte, culotte is a bit more complex lesion, and I would always recommend to you to go to start, if you plan culotte, then try to go to the more angulated vessel, which is usually side branch is more angulated. and this is the safest way to perform this culotte technical approach. The diameter difference should be maximum 1 millimeter between side branch and main branch. Let's say 2.5, 3.5, it's fine, but 2.5, 4.0 will be not perfect. You open now this main branch to the distal part, and you can do this with one balloon, or you can do this as a kissing maneuver, and then it will be the name double kissing culotte. And I show you one more slide to this point. Then you go with a stand to the main branch. In this animation, the side branch stand is a bit too long. I would always recommend to have around 3 millimeters. So then rewiring, and again, very close to the carina, final kissing, and of course, really very necessary and obligatory to perform pot. So the post-dilatation are the crucial point in this technical approach. Again here, very nice result to both branches with no floating struts to the main branch. And you see, if you just open the struts with one balloon, that's a classical culotte. But if you do first here open struts and you have balloon in the stand, it's a kissing maneuver. This is first kissing, and if you already stand at the main branch or other branch, then you do second kissing, and this will be the final kissing. So this will be double kissing crush. And like here shown in this slide. And finally, we have Dickey crush, and there are many, many different steps. And we have definitely always follow all the steps, step by step. And here again, from Gianni's some animation for younger doctors, just to understand how many different steps are needed, are necessary. And you stand always to the main branch. We have here balloon in position, you crush, and then you wire in the middle or proximal wiring, and kissing, first kissing, and then you usually go direct with the stand, pot, wiring again in the middle of side branch ostium, final kissing. This is the second kissing, and of course final pot. So this is all steps from Dickey crush, and you have here very small segment with 3 layers of struts, but this is usually, if you just take a look into OCT, it's really no big problem. And if we compare double stenting studies, so we have Nordic 2 study compared crush and culotte. There was a trend to better results with culotte. In our BBK2 study, we've compared in randomized trial TAP with culotte. The result was clear. We achieved better results with culotte, especially in the side branch, because we cover perfectly the ostium of the side branch. And even by clinical follow-up 1 year post PCI, we had definitely a very clear trend to better clinical outcomes after culotte. What is really very important if you perform double stenting, final kissing angioplasty with double kissing with 2 balloons is absolutely obligatory. In some cases, you could even leave the side branch without any procedure. Nordic 3 study showed there is, even if you have simple bifurcation lesions, you can go with only membrane stenting. According to the distal left main, we have a Dickey crush 3 study. They compared Dickey crush and culotte. There was a better result after 1 year for Dickey crush, and Dickey crush 5 study. It was a comparison of provisional T-stenting and Dickey crush, and also here there was a benefit for Dickey crush compared to provisional approach. And we were really in Europe, we usually go for distal leftman with provisional, and we finally were ready to finalize our ABC main study, compared provisional approach with double stenting. We used here exclusively a Resolute Onyx stent, and the composite, and the primary endpoint was composite of death MI and TLR at 1 year. I just show you here. So the Onyx was our stent, and we had in around 20% the crossover to double stenting, and the primary endpoint was very clear. There was a trend to better results if you go provisional, if you go with provisional approach compared to systematic double stenting. And you see there was here the trend 6 versus 9% TLR rate after 1 year. And here just showing you 15 versus 18%. So it was interesting to compare this data with Dickey Crush. And as you can see, we have similar numbers of patients. We have lower syntax score in ABC main study, 23 versus 31. We have shorter side branch length compared to Dickey Crush. We have 20% crossover. In Dickey Crush 5 study, it was over 45%. And we use it in more than 50% culotte. And also TEP was used in 1/3 of patients. Dickey Crush in ABC main study, only 5%. And you see, both studies had only 40% of use of IVUS use. Quite better results with Dickey Crush, but please not forget, we have here all-cause death in ABC main study, and here's a cardiac death. That's make the difference. And so I just show you the point. If you go with TEP stenting, which is usually the most popular approach in Europe, and if you have this position for the side branch, it will be really very difficult to manage this. If you go too much to the side branch, you will have gap. So optimal position is if you have protrusion from the side branch stent to the main branch vessel of around 0.5 millimeters, and then you go forward, you make kissing final pot, and you usually produce such a result for the side branch. Okay, thank you so much, and I hope we can discuss this.